I'm Ganiyat Oyeleke. I'm a liver specialist and gastroenterologist at LUTH. It's the Lagos University Teaching Hospital in Nigeria. I'd like to re-echo what the other speakers have said. It's been a very wonderful conference here. It's my first interest conference, and it's really, really lovely. And I would like to applaud the organizers for inviting me and putting this up. Thank you very much. So I'll be discussing hepatitis elimination in sub-Saharan Africa, and I have nothing to declare. So I'll be doing so under this outline: introduction, the current situation, the challenges, way forward, and conclusion. By way of introduction, the sub-Saharan Africa, we have about 46 countries and an estimated population of about 1.3 billion. Majority of the economies are low income, and majority also are rural population, with urban population of about 30%. In terms of epidemiology of hepatitis B, you can see that the sub-Saharan, we have a very high burden, particularly in West Africa. And you can see Nigeria somewhere there, which is where I come from and I practice. But even aside Nigeria, the other sub-Saharan African countries also have high intermediate prevalence, as you can see. And moving to hepatitis C, we also have a huge burden as well. Certain countries in sub-Saharan will have prevalence of more than 5%, while some have intermediate moderate prevalence between 2.5 to 5%. About 62.5 million Africans have chronic hepatitis B, and chronic hepatitis C accounts for about 10 million Africans, sub-Saharan African population. I'm going to use Nigeria as an example, not just because I'm Nigerian, but because it's also the most populous country in Africa, with an estimated population of about 186 million. The average prevalence of hepatitis B in Nigeria is 11.7%, while we have 2.2% for hepatitis C. An estimated 21 million individuals, that's like twice the population of Rwanda, I'm sure, currently have hepatitis B infection, while about 4 million will have hepatitis C. The prevalence is very high in rural communities in Africa, and it's also point to note that about 5 million people die yearly from complications of hepatitis B, particularly liver cirrhosis and hepatocellular carcinoma. And it's also sad to know that majority of them are in the young age group of 30 to 50 years. The story continues. Treatment of hepatitis B and C in Nigeria is usually in tertiary centers, and there's significant inequality in access to care. We have about 130 liver specialists to take care of about 25 million population with hepatitis B and C. So this is grossly deficient. And also because it's a silent disease, most times the first presentation is with complications. So it's a picture of someone presenting for the first time with a huge mass at the right upper side, which is liver cancer. So we see this a lot. And the tiny scars on the surface, the incisions that have been, apparently the patient must have been having some complaint, but instead of seeking medical treatment, had gone to do some native scarifications. So we see this a lot. While the global mortality for tuberculosis and HIV and malaria appears to be dropping, viral hepatitis mortality is on the increase, and this is cause for concern. And based on this, the WHO in 2005 brought out their elimination targets. Just like the target for HIV, which is the 90-90-90, the 2030 targets hope to have 90% reduction. 90% of infants born would have received 3-dose hepatitis B vaccine. 90% reduction in maternal and child transmission of hepatitis B, about 90% injection safety, 90% of diagnosis being made for viral hepatitis, both HBV and HCV. At the moment, it's less than 5%, so we have a lot of missing diagnoses. Also, 80% of those eligible to treated, it's postulated to have been treated by 2030. We're hoping and praying we'll be able to achieve this because it's still a long road. And the impact of this is that there'll be 90% reduction in incidence of chronic hepatitis B and C. And overall, the mortality that stands at about 1.46 now would be reduced by 65% by year 2030. It's important to note the birth dose. Majorly in sub-Saharan Africa and particularly in Western Africa, there's a lot of childhood infection. And so the childhood infection will be like transmission from mother to child. So it's important to have a birth dose of vaccine. At the moment, not all the countries in sub-Saharan Africa have commenced the birth dose of hepatitis B. This is the WHO estimates of countries so far that have commenced the birth dose. And you can see that just about 15 countries so far as of 2017. So it's important to be able to implement this to prevent mother-to-child transmission and even child-to-child transmission of infection. Now, what are the challenges? The challenges I've summarized in this are 5 lacks. The lack of data, compared to what we have in hepatitis B, in HIV, viral hepatitis, we're really, really deficient in data. There's also lack of engagement. There's lack of funding. There's lack of planning and lack of action. There's inadequate government advocacy, leadership, and commitment to viral hepatitis treatment. There's very limited funding. They were talking about funding for tuberculosis. In fact, I was discussing with Nesri, and he said tuberculosis, the funding for TB is way behind. I said for viral hepatitis is way, 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 way behind. So it's a huge challenge, I must say. There's poor implementation of national strategies. There's a public health sector approach to hepatitis screening, which is still in infancy. And of course, the high cost of medication. And it should be noted that majority of sub-Saharan Africans will still pay out of pocket for treatments. And we should note that for hepatitis C treatment particularly is quite expensive. There's information gap, deficiency for both for disease, the economy burden, and the treatment. Yeah, this is recent funding. And truly, you can see that viral hepatitis is way, 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 way behind HIV, behind STI, and behind tuberculosis. So I think we have to do something about that. How? We need to know. Other challenges, like I've said, it's lack of data for action, data for advocacy, and data for strategic planning. There are also multiple barriers to screening and linkage to care. We have issues of stigmatization here as well, and certain cultural beliefs which have impaired treatment moving forward. Diagnosis of liver disease and hepatitis treatment challenges, poor health infrastructure, and the dearth of human resources and personnel. Now, what's the way forward? It will take a combination of factors to be able to push the way forward. And that is, we need to have country ownership. There has to be integration of hepatitis services into the health system and strategies, effective partnership, a public health approach, intersectorial cooperation, and universal health coverage. Regarding the country ownership, there has to be government commitment and leadership to ensure that the national hepatitis response is led, coordinated, and owned by member states. They have to also train health workers, both the middlemen, the middle level, and the community health workers. There has to be a lot of research and surveillance if we have to move forward. Integration of hepatitis services into the health system and strategy. This would help by avoiding standalone viral hepatitis programs and strengthening interface between health sectors and other sectors. Up until 2016, even in Nigeria, we did not have like a national hepatitis treatment guidelines. I'm sure other countries in Africa may probably have the same story. We need to have effective partnership for multi-sectorial cooperation involving all sectors of the society and ensuring that all partners align the support for national hepatitis response. Partnership with civil society and patient advocacy groups and non-governmental organizations. In terms of partnership, there has to be partnership for diagnosis. Recently, the Clinton Health Access Initiative partnered with some centers in the country to provide treatment for HIV, HCV co-infected individuals. So we need more of this to be done. And they've also assisted in subsidizing the HCV, hepatitis C viral treatment care, which initially was almost unreachable for the average Nigerian, but the cost has been reduced to about a quarter of what it used to be now. So this, hopefully, this is going to be extended to other states in the country and other countries in the sub-Saharan region. There can also be, we can leverage on the existing structure. The gene expert that was used for tuberculosis can actually also be used for the assays of hepatitis B and hepatitis C. So, and the gene experts was adopted by the National TB and Leprosy Control in Nigeria in 2011, and they've installed over 300 machines across the country. So if we can leverage on this, that will help to reduce the cost of the viral load and some other investigations. We can also leverage on the Roche PCR. The Roche PCR was used for, is being used at the moment for the HIV control, the HIV viral load. So, and we currently have about 47 all over the country as well. You know, so I'm speaking from Nigeria. I'm sure probably in some other African countries this applies as well. So there's need to ensure the resources and performance are maximized towards optimizing capacity. There has to be partnership in capacity building and training as well. We've had trainings, there's the International Coalition for Hepatitis Education Providers, and Clinton Health Access. SOGIN is the Society for Gastroenterology and Hepatology in Nigeria, and certain pharmaceutical companies. They've partnered with us in training and retraining primary care physicians and some specialists. And this was in one of the recent trainings we had. It will also take a public health approach. The approach based on simplified and standardized interventions and services that can rapidly be taken to scale and bringing them nearer to the needed population. And so this, I know, has been what it's been done a lot in the HIV program. And so if we borrow from this, this will also help in pushing the way forward. And intersectorial cooperation. So the key stakeholders, healthcare workers, the pharmaceuticals, the civil organizations, the patient advocacy groups, they can all work together to create a sustainable, locally appropriate solutions to limit the burden and on the healthcare system in the communities. Universal health coverage is also a way to go to ensure that all patients, all people obtain viral hepatitis services they need without suffering financial hardship. Majority of African countries still have issues with health insurance. I must commend Rwanda. I think they have about the best health insurance in Africa. So I applaud them. So it's really the way to go. We're still battling with that in Nigeria, and I'm sure the story is the same in most sub-Saharan African countries. Community-based health insurance may be the way forward. Innovative price reduction models, and treatment subsidization, as we have in HIV, malaria, and TB control through international donors, and sustainable funding. Now, in conclusion, the vision is to have a world where viral hepatitis transmission is halted, and everyone living with viral hepatitis has access to affordable, safe, and effective treatment and prevention services. And the goal is to eliminate viral hepatitis as a major public threat in year 2020 through these various strategic directions. In summary, viral hepatitis in sub-Saharan Africa is a silent epidemic. The co-infection with HIV only makes things worse. Overcoming challenges requires individual government commitment, patient advocacy, civil society organization. It requires strengthening African collaboration, international collaborations, health insurance, and health management organization. I'm leaving you with this. Every July 28 is World Hepatitis Day. And the theme for this year is eliminate hepatitis and find the missing millions. There's so many more that haven't been diagnosed, and we're hoping that we'll be able to find the missing millions to achieve the 2030 targets for elimination of viral hepatitis. I acknowledge my colleagues at the teaching hospital, and thank you very much, and Murakoze. Thank you.